Good evening. Welcome. My name is Raj Safalkar, and I'm pleased to welcome all of you here to the 2019 Schirber Lecture with Dr. Jani Jensen. Before we introduce Dr. Jensen, I'd like to tell you a bit more about the lecture. The Schirber Endowed Scholarship and Pre-Med Fund at St. John's University was established by Dr. Martin Schirber, class of 1942, and his wife, Mrs. Rosemarie Schirber, from Grand Rapids, Minnesota. And Dr. Martin practiced medicine in Grand Rapids most of his medical career. A number of his sons and daughters also graduated from St. John's University and the College of St. Benedict. And we are joined today by three members of the Schirber family: Steve Schirber, Jani Schirber Hecker, and Jay Hecker. So please thank them. The purpose of the Endowed Fund is to provide for the support of a lecture program, 2 annually, intended for students in the health sciences. So I'm glad to see several students here, but open to all. One lecture is on medical ethics, and the other lecture is on alcoholism. And so I encourage you to look for future Schirber lecture programming. And if you have suggestions for our committee of interesting and excellent speakers in these areas, we're always looking for great ideas. The Schirber Endowment also funds several scholarships. So a number of students at St. John's University who are planning into going into medicine receive scholarships from the Schirber Endowment. So we're very grateful for Martin and Rosemarie Schirber. And now to introduce our lecturer today, Dr. Jensen. She is the reproductive, and she's a third-party reproduction director at Reproductive Medicine and Infertility Associates, RMIA, in Woodbury, Minnesota. Prior to working at RMIA, Dr. Jensen was the IVF director at Mayo Clinic in Rochester, where she was also an assistant professor in the Mayo Clinic School of Medicine. She had joint appointments in the Department of Obstetrics and Gynecology and in Medical Endocrinology. She served as the medical school's obstetrics and gynecology clerkship director and diversity director. Dr. Jensen is a member of the Society of Reproductive Endocrinology and Infertility, the American Board of Obstetrics and Gynecology, and the American Society for Reproductive Medicine. Her research focuses on fertility preservation, which we'll learn about today, and improving in vitro fertilization techniques and outcomes. Dr. Jensen's lecture will discuss ethical questions related to fertilization and advancing technology to support ethical decision-making. Please join me in welcoming our 2019 Schirber lecturer, Dr. Jani Jensen.
Well, thank you, Raj, and it's a real honor to be here at your beautiful campus. This is my first time. Perfect night. Thank you, whoever ordered this. It's wonderful. And it was very humbling to meet some members of the Schirber family. What a tradition your family has for this institution. So thank you for sharing some of that with me. And I'm very pleased to talk about a field that I love tonight, but I do have one disclosure for you. So throughout my career, I've been fortunate enough to speak to 5,000 of my colleagues about my research. I've been on NPR, The Today Show. I wrote a book. It got translated into Japanese. I have mastered the art of the awkward half stare, I guess in the middle there. Starred in many boring YouTube videos, but I'm the most nervous to speak to you tonight because I feel that perhaps with some of what I do, at first there may appear to be some fundamental tension between some of the ethical principles that people in the room may believe in. And I hope in the time that we have to share together tonight, we can come to a place of understanding and that we are really coming from the same place, which is we're trying to help patients build families together. So let me tell you a little bit more about this field that I'm in. And advance, okay. Why I love it. So reproductive endocrinology. To do reproductive endocrinology, after you graduate from medical school, you do obstetrics and gynecology residency for 4 years. And of the people in obstetrics and gynecology, approximately 35 people a year train for 3 additional years to become a reproductive endocrinologist. So it's a long process, 4 years of medical school, 4 years of OBGYN residency, 3 extra years of training. And while the field is not new, like many fields in medicine, it's one that is constantly evolving. And I love this intersection of the 3 areas that it represents: medicine, technology, and ethics. I'll also share with you that I think one of the difficulties about the profession is that it's estimated that our science and technology moves about 15 years ahead of legal decision making and ethical decision making. So in this field, there also comes, I believe, a huge responsibility to use our technology wisely and in ways that are safe and ethical. Let me also explain a little bit of who we see and the scope of the problem. So while I see patients with many unusual reproductive disorders, some of the most interesting things I think that we can see in medicine, one of the primary areas of focus that I see are couples that have infertility. So approximately 15% of couples have difficulty achieving a successful pregnancy. So the math isn't perfect, but it's roughly 1 of 6 or 1 out of 7 couples. And it might be for the first time they're trying to achieve a pregnancy, or it might be for that 2nd, 3rd, or 4th baby. And unfortunately, infertility is a condition that's often not talked about or sometimes stigmatized. I have many patients also tell me that they get very unhelpful advice, sometimes from well-intentioned family members or other people who say, just relax, it'll happen, and if you're born without a uterus, it's not going to happen. So this is something that, even if it's largely invisible to some extent, it is there. And this is actually National Infertility Awareness Week, so the timing of the lecture is very appropriate as well. And we'll talk in great detail about in vitro fertilization, or IVF, but currently, worldwide, a record number of couples are using this technology to achieve a pregnancy. And this number continues to grow. So it always takes us quite a bit of time to be able to get a handle on our statistics, because not only do we have to have patients get pregnant, but we have to wait for them to have their baby. So the most current statistics that we have come from 2016, where we learned in the United States that there were over 237,000 procedures that I'm going to describe, and this resulted in approximately 66,000 babies being born. Currently in the United States, in vitro fertilization accounts for about 1.5% of all babies that are born. Worldwide, in some other countries where the healthcare system is different, where populations are shrinking rather than growing, we actually see a higher percentage. For example, in some of the Scandinavian countries, the number of babies born from in vitro fertilization is over 5%. Now, I'm going to talk primarily about in vitro fertilization, but before I get started on that, I want to briefly mention that everything that we do falls under an umbrella that we call Assisted Reproductive Technologies, or ART. Now, in the early days of this type of treatment, we also saw some other procedures that are not as common now, but particularly for people who are students of history of science, or who are perhaps of an older generation, maybe have heard of procedures like gamete intrafallopian transfer. So this is where we take eggs and sperm, surgically put them inside the fallopian tube, hope they find each other. Or, one step further, combine sperm and egg with surgery directly into the fallopian tube. Now, in the early days of in vitro fertilization, and we'll talk about this in a second, in vitro fertilization did not work well. The success was extremely low, and these other 2 procedures were much more successful. With the advancement of technology, and in the 13 years I've been in this field, I've been able to see the needle move really well in this front. Now what we see is that over 99% of everything that we do is actually IVF, and the other procedures are largely of historical interest at this point. Before I go further, though, I would like to just say for a few minutes, address something that maybe someone in this room is wondering, which is why would you do this at all and why not just adopt? So this is a very complicated answer to this question. And number one, it's not actually that easy to adopt in the United States. So I have many patients who have chosen to go the route of adoption, and I think this is an incredible opportunity, and I would wager also that 100% of the people that have chosen that route feel like that was the predestined route that was right for them. However, it can be a process that takes 2 or more years in the United States, and it also can be extremely costly, not that cost is the only issue for it. And it's not always possible. So what I mean by that is, in modern adoptive practices, there are some places that will exclude certain types of patients from being able to adopt. A cancer survivor would be kind of one example that some people may discriminate against, thinking that their health might not be good. Gay or lesbian couples, single parents. So even if you want to adopt, sometimes it may not be possible. And I think, I hesitated to put this last point in, but I think this is really important. I think this comes back to sometimes you have well-meaning family members that may say something like, well, why don't you just adopt? But to the patient that's going through infertility, that I think can be a very alienating and devaluing sentiment, taking away sort of their perceived natural, normal, and rightful desire to actually become pregnant and have their own baby as well. Adoption statistics are also kind of hard to come by, so I know these are a few years old, but this is our most current data. So in 2014, there were over 100,000 adoptions in the United States, but about 40% of these are actually within the same family. So that means grandparents are adopting grandchildren, blended family gets remarried, stepdad adopts the kids. That's what we're talking about here. And another half of the adoptions are from the foster care system. So that's where the greatest availability of children are available for adoption. So I think if you're back to that patient that says, well, I just really want to have a baby, domestic infants in the United States were less than 20,000 in 2014, and that's 0.5% of all the live births in the United States. So it's actually a very small percentage of newborns in the United States that are available for adoption. Worldwide, adoption numbers have also trended down over the last decade. They reached a peak in the like 2005 to 2008, where we had nearly 25,000 international adoptions, but through a combination of some countries excluding US citizens from adopting, and the US barring some citizens from adopting from countries with practices that weren't in accordance with the Hague Convention. Now we saw in 2016 only about 6,000 international adoptions. So if anyone again is thinking why not just adopt, it is possible, but not always as easy as we might think. So returning to in vitro fertilization. By the way, this is not what we do. So I like the visual of this, so I've used it several times, but certainly this is not what things look like inside our practice. But to understand in vitro fertilization, we need to start at the beginning. So this was the Evening News in London in July 1978. And this was announcing the birth of Louise Brown, the first baby born from in vitro fertilization. So here's Louise last year when she turned 40. This was a big deal. She's kind of a rock star in our community. She was on a flight behind me and my business partner. And we were both like, there's Louise Brown, you know, like, can we kind of, you know, should we take a quick like selfie and pretend? But yeah, so Louise is now a postal worker married with her own children in England. So Louise's parents were really the pioneers, though. That's them pictured. Her mom had had 2 prior ectopic pregnancies, so pregnancies in the fallopian tube, that required her to get both of her tubes removed. So in the 1970s, they had no way to successfully conceive without fallopian tubes. Now, the physicians who ultimately were awarded the Nobel Prize for bringing this technology to practice, Dr. John Edwards and Dr. Patrick Steptoe, tried 282 times to create a successful pregnancy before Louise was born. So the chance of success for that would be on the order of 1 or 2% before there was success. But in 1980, the first baby was born in the United States at the Jones Institute in Norfolk, Virginia. She is Elizabeth Carr. And approximately 8 years after Louise was born, her younger sister became the 40th baby born worldwide from IVF, and history has taken off since then. But I give her parents tremendous courage because there was a lot of scrutiny and negative publicity around her birth when it came. But ultimately, again, the physicians won the Nobel Prize. Now, one thing that is also important to understand is that when Louise Brown was born, the doctors who created her embryo were only able to get 1 egg out of her mother at a time. Now we have medicines that let us get more than that, but let me explain just a fundamental concept. So I explain this to patients a lot, and I always joke and say this is 8th grade health class in 30 seconds. It's actually probably more like college sophomore health class, I don't know, or maybe you're way advanced beyond this too. But it's kind of important to understand the events of a normal menstrual cycle to have this make sense. So women are born with all the eggs that we're ever going to have. And actually, that's not true either. So, I kind of told you a lie already. So when our mothers are pregnant with us, when we are about 6 months in utero, we typically have about 6 to 7 million eggs. But not every egg becomes incorporated into a sac. That's called a follicle. So by the time a baby girl is born, she has 1 to 2 million eggs. And that number does continue to decline until we reach a point of what's pejoratively called ovarian exhaustion, and that's menopause. But in a normal menstrual cycle, what is supposed to happen throughout reproductive life is that there's always a group of resting eggs. Most reproductive age women are going to have every month about 10 to 25 eggs that are ready to come up to the starting line and be able to compete to be the one that gets to be ovulated. And usually only one wins. Rarely you can have 2. 1% of the time humans spontaneously conceive twins in a menstrual cycle, but usually only 1 egg gets to win the race. And the rest of these eggs that were competing in that particular cycle are lost through a process of apoptosis or programmed cell death. So they're lost by the wayside. After that winning egg is ovulated, your body waits around to see if you're pregnant. If you're not pregnant, you get a period, and the next month, a new race starts again. So even if everything that I just said on this slide, you let go in 1 year and let go out the other year, let's think about it this way. So this is the Nike Women's Marathon in 2012, and I realized that was a long time ago, but I'm in this crowd. So what you can't see is that I'm about 5 blocks back, and it's 5 o'clock in the morning, and it's kind of cold outside that day too. But I wanted to do this race for a long time. I love to run, and there were a couple of reasons. One is they had a chocolate mile where they gave you chocolate. And another is at the end of the race, instead of getting a regular medal, you get a Tiffany necklace, and it's handed to you by a gentleman wearing a tuxedo on a silver tray. And I thought, that is my race. So along with 10,000 other people, I lined up. I'm 5 blocks back, the starting line in 2012. However, this imagine as the start of the menstrual cycle with that group of eggs that are trying to compete, but only one person wins the race. Now, spoiler alert, that's not me. So you may be confused and think I won the race, but that is not me. And I actually don't know who that was. I had to Google her because I never saw her. She was way ahead of me, and we never met. But think about this. This is the normal menstrual cycle. So one egg gets to win, and everybody else is slogging away up this hill. That's a terrible hill, by the way. I am surprised I didn't need CPR halfway up. But it's in San Francisco. It's, very, very hilly terrain. So these are the way I think of all those other eggs. And really, when we're doing fertility treatment, particularly IVF, what we're trying to do is get multiple eggs to win the race simultaneously. So we're not just getting a bunch of eggs that are trying to compete and letting one egg win. We're trying to get everybody to get to the finish line that starts the race that month. That's also not me. So, all right, so how do we do it? So we teach women to give themselves hormone shots, and for those of you who are interested, there's synthetic versions of the hormones that your brain makes on its own. So those hormones are follicle-stimulating hormone and luteinizing hormone. But this encourages multiple eggs to simultaneously develop. And it takes about 10 to 12 days before we get that group of eggs ready. And we have to follow really carefully how well the eggs are growing in 2 ways. One is we get blood tests. We're measuring the hormone estrogen to see how high it gets. It gets about 10 times higher than it normally would in a normal menstrual cycle. And we also monitor by ultrasound. So we're doing ultrasounds to look at the ovaries, and the eggs are actually too small to see, but we can see the sacs that the eggs grow in that are called follicles, and we know when these follicles get to a certain size that the eggs are going to likely be ready inside. And what we don't want to have happen, though, is the eggs to release too soon. So we want to go in and harvest the eggs at a point where they're mature, but we don't want to let the body start ovulating them out of the ovary on its own. The process to get the eggs out of the body is one that's done with anesthesia. It takes about 10 minutes to do, and we have to put a needle into the ovary under ultrasound guidance. Once we have the eggs out, we look at them underneath the microscope, and we're looking for eggs that are at a specific stage. We want ones that are mature in what we call the metaphase 2, and we'll fertilize those eggs in our lab, and now we have embryos that are available. And we'll typically watch embryos develop in our lab for a period of time, usually between 3 and 5 days, until we can select the embryo or embryos that we want to transfer to the uterus. So I explain to patients when we're picking the embryos that we like, this is like dating. So we watch the embryos, we're dating them, we see how they act, we see how they develop. We want to reach a point where we can commit to them and put them back in the uterus. So this is a cartoon drawing, but it just shows a schematic of how we get the eggs out of the ovary. I've even had patients feel extremely surprised when they showed up for their egg retrieval to find out that we're actually going to put a needle into the ovary. They may have not been listening up front when I was counseling them, but we have an internal ultrasound, which you see that goes through the wall of the vagina. The ovary is on the other side of the vaginal wall. And then under ultrasound guidance, we have a thin but very long needle that we can direct into each one of the follicles. We can't see the egg, but we can see the follicle, and we can watch it collapse, almost like a grape that becomes a raisin as we take the fluid out. And then the fluid is sent to our embryology lab, which I guess the best way I can describe this is almost like a drive-up window. So it's connected to our surgical room. And our embryologists are looking at the fluid underneath the microscope to separate the eggs out. And here's a human egg. So this is what a human egg looks like under magnification. There's actually a couple of sperm down around 5 o'clock that are hanging around next to it. But a human egg has the egg itself, and then there's a supporting group of cells called granulosa cells that are on the outside. I still kind of think of it like a chicken egg, where the egg is the yolk and then you've got a white surrounding it, but the analogy isn't quite right. And then we can try to fertilize the egg. So there's 2 ways that we can try to fertilize the egg. One is we just mix sperm and egg together in the lab and we come back to check a day later. Or when we know that we have very low sperm numbers or we have problems with how well the sperm works, we can actually inject 1 egg into each sperm to try to fertilize it. So this is a process that's called intracytoplasmic sperm injection, or we abbreviate it ICSI. So this photo that I'm showing you here is a human egg, and at the 12 o'clock position there are polar bodies. So that's when an egg is ready to be released. It reduces some of its genetic material. The polar bodies are extruded. And what you see at the 9 o'clock position is a very tiny holding pipette that has a small amount of suction that's holding the egg in position. The glass needle has a single sperm in it that's been captured and trapped. It's down at the tip. And that glass needle that you see is going to pierce the oolemma, which is the sort of soft shell around the egg, and inject the sperm directly into the egg cytoplasm. And you have to do this very, very, very carefully without damaging the egg. The risk of doing this in experienced hands is less than 1% risk of damaging the egg. And what you also cannot appreciate from this is that needle is about the width of a hair. So this is a very, very delicate procedure. So we have an embryology staff that trains for years before they're able to do this. I tried to learn this technique using starfish eggs when I was a fellow, and after I had broken about 40 needles, my privileges to use the microscope were completely stripped away. So I was not proficient in attempting to use this at all. So we get the eggs out of the body. We try to fertilize the mature ones in our lab, but we can't tell immediately if the egg is fertilized, so we have to come back the next day. So when a human egg is successfully fertilized, it looks different. So what we're seeing here is a 1-day-old embryo, and it hasn't started dividing yet. So we've got the egg, we've got support cells. There are a lot of sperm crowded around the outside of this particular egg. One has successfully fertilized it, but others have been trying. At the 3 o'clock position here, we can see polar bodies, but in the center, what looks like 2 eyes, that is now a nucleus from the egg and a nucleus from the sperm. So this, we can tell, is a fertilized egg that now has genetic material combined not only from that egg, but from that sperm. And from here, we're going to watch the embryos grow. So I have pictured here a couple of embryos that are between the 8-cell stage and the blastocyst stage. So the one that is on the left of the screen is an embryo that's approximately 8 cells, and it looks really nice. So all the cells are really even, and they're about all the same size. They don't have any grit or abnormal texture inside the cytoplasm, and this is an embryo that's about 3 days old. The embryos on the right, the one that looks like a raspberry and the one below, these are blastocyst stage embryos. So these are more advanced. They're 5 to 6 days old, and instead of having approximately 8 cells, now they have around 200. And they take on a different shape, and you can see it better in the bottom picture. So there's a ball of cells on the inside, and that's going to be the fetus. So that's going to be the future baby. The cells on the outside are called the trophectoderm, and that's going to be the future placenta. So back to my dating analogy, we like to watch the embryos grow and develop in our lab as long as possible to figure out if we can get all the way to that blastocyst stage, which is where we like to get the embryos, and that's where they implant in the uterus. So this process would have to, an embryo would have to develop to that point in the body in order to be successful. What is part of the art and the difficulty, though, and this is a very technical thing that I'm about to tell you, is that not every embryo can reach the stage of the blastocyst. So roughly up until that 8-cell stage where we see that embryo on the left, a lot of the divisions that are driving the embryo to develop come from the egg itself. And the embryonic genome, or the embryo itself, now has to kick in its own machinery to keep the embryo developing to be able to reach that blastocyst stage. So we know that there will be some attrition of the embryos between the 8-cell stage and the blastocyst stage. To put the embryos back in the uterus, this is a fairly quick procedure. We use a catheter that's like an overcooked piece of angel hair pasta. It's extremely flexible, extremely soft. We put 1 or typically at most 2 embryos inside the catheter and very gently put it inside the uterus. The embryos are in a 20 microliter drop of media. And because they're so small, once we deliver them into the uterus, we have to double check the catheter since they're microscopic to make sure that they actually got delivered. And I always say we got to see that they got off the bus. So, and then 10 to 12 days later, we get a pregnancy test. So we don't get this type of pregnancy test. We actually get a very specific one that's a blood test with numbers, but that's not as interesting a visual for the crowd. So. Now, how well does this work? So when Louise Brown was born, I told you that it was a 1% chance of success, not even 282 procedures to result in 1 live birth. Today, we're still not at 100%. I was at a medical conference 2 weeks ago, and I was talking to some of my physician colleagues in different specialties, and I said, even when I'm doing my job the best I possibly can, the chance of success is less than 70%. So that's something very difficult to rectify, I think, when you're a physician, when you want to do so much good for your patients and you know you're never going to be 100%. Having said that, When I started in this field, the chance of success was about half that much. And for us, the primary determinant of success is the age of the eggs. So younger eggs always do better. When you have women that are less than 35 years old, you can see this blue line at the top. The pregnancy rates have increased over time. In our practice last year, when we had women who were less than 35, we had about a 57% pregnancy rate when we put one embryo in the uterus. Now, unfortunately, the chance of success for IVF also drops very precipitously as women go through reproductive aging. So by the time you get to age 42, the chance of taking home a baby for most patients with their own eggs is less than 10%. So age is a very important determinant. But there's also a lot of important considerations, and this is one of the things we're here to talk about tonight. So multiple pregnancy. Twins look adorable on the picture, but a twin pregnancy is a lot more complicated. Ask any pediatrician, they'll tell you that twin pregnancy comes with more risks than pregnancy that we call just a singleton, so we have to be really cautious. Now, I'm happy to report that as our field has advanced, we have had fewer of the really scary pregnancies. Octomom, anyone remember that? Okay, so that was way outside any of our boundaries and guidelines, not one of my patients. But even the high order multiples, that triplets have been reduced. But we still have a twinning rate of about 20% in what we do. And statistically, if you got pregnant naturally, the chance of having a twin pregnancy is only about 1%. So we increased that quite a bit. People wonder, is it safe? So this has been looked at multiple ways too. If I do IVF, am I going to use up all my eggs that I need to try to have another baby? No, we're just catching the ones that otherwise would have been lost. Is it also possible that my future fertility is going to be worse, or I'm going to get something like ovarian cancer or breast cancer from using your medicines? So this has also been well studied. One longitudinal study that came out of Scandinavia looked at 10,000 women that had done fertility treatment and followed them on average for about 10 years, but some as many as 20 years. And we saw that this didn't increase the risk of doing this type of treatment of having any malignancy or worse health concern down the road. But one of the other concerns that we have are, what would we do if we had more embryos than we need? So disposition of extra embryos is something that we think about a lot, and it's really important for patients who are thinking about doing this to think about it before we go forward with the IVF process. Because if we have more embryos than we need, we can use them in a few ways. Now, one is embryos can be stored for future attempts at pregnancy. So if you were a woman who went through this process at 32 years old, say you created 4 embryos and we used 2 now, but you had 2 that were frozen, those can be used for future attempts at pregnancy. So we still have to give medications to prepare the lining of the uterus to do what we call a frozen embryo transfer, but the success of these embryos is very high. So with modern freezing techniques, embryos survive the freeze-thaw process more than 95% of the time. And one of the huge advancements that we've had is now frozen embryos work as well as fresh embryos to create a future pregnancy. Another way of saying this is something patients don't realize quite a bit, but if you are also 32 and you create embryos and you have extra embryos, they don't expire. So you could come back and use embryos 2 years later, 4 years later, 10 years later. There was a story a year ago about embryos that had been stored for 25 years that were used, which is incredible. Now, most people don't plan their family that way, but it's possible. And if you made these embryos when you were 32, even if you are now 42, we talked about 42-year-olds don't have a high reproductive potential on their own, but if you had embryos created when you were 32, those embryos actually have the potential of a 32-year-old mother, not a 42-year-old mother, because they're frozen in time. So number one is we want to save the extra embryos to potentially use for future attempts. Now, what I'm about to tell you next is something that isn't that common, but also can be done. We can donate embryos to other couples. So we don't like to call this embryo adoption, but embryos can be donated. It's not a huge percentage of what we do in our practice. So in our practice, we probably have about 5 or 6 cases of embryo donation every year where embryos are received very generously, donated by couples who've completed their families to couples who are thrilled to be able to get them. There's a very extensive process that has to be done. There are some patients that have extra embryos that want them returned to their uterus, but not in a way with any extra hormonal support to try to encourage the pregnancy to develop. So we're putting them back in their correct environment. We're not giving additional medicines to try to encourage them to continue to develop, though. But probably the best way that we can limit the number of embryos we have and having to make those difficult ethical decisions about our extra embryos is to limit the number that we create. And this has been a really exciting advancement in the time that I've been in this field. What I'm about to tell you was not possible when I started in 2005, but now it is, and it works really well for some patients and as a great option. So remember this? Remember when I won the Nike Women's Marathon? Just kidding. Back to this analogy. So typically when we have that group of developing eggs and only one wins, we're trying to do our treatment to catch all of these other ones. So when we do limited insemination, we're actually trying to catch all of these, but we're only letting one win. So let me tell you what I mean by that. So we can obtain 10 or 15 eggs from a patient, but maybe we only try to fertilize 1 or 2. Maybe we don't create any extra embryos. And it's very, we already talked about the process to be able to create the eggs. And so you have to do a lot as a patient, lots of shots, lots of monitoring. You have to go through a surgical procedure. But what if we could save those extra eggs? So it's now possible to be able to freeze extra eggs in an unfertilized state. So these are those eggs that otherwise would have been lost along the way. When I started in the field, people had made attempts to try to fertilize eggs dating back to the 1980s, but they were very unsuccessful. In contrast, does anyone, I'll ask, but I'll tell you the answer really quickly. Does anyone want to guess when the first baby was born from frozen sperm? 1952. So we have many men in the audience, so I'm going to carefully say this next piece, but sperm are relatively simple. So sperm are very easy to freeze and thaw in general. They survive really well. It's to some extent a renewable resource, and sperm banking is very well established. So sperm banking is also not really well established not only in humans, but also in cows, in racehorses, in dogs. So we owe a lot of debt to the industry that we're in, to veterinary medicine, and sperm banking has been a huge part of it for decades. But eggs are different. So the human egg is one of the largest cells in the body. The only competitor for it is a neuron with its long axon, but the egg is actually more complicated. So a human egg is very difficult to try to freeze for 2 reasons. One is that the human egg contains a lot of water. And so early attempts at trying to freeze eggs caused a lot of ice crystal formation inside the egg. So human egg is obviously very different from a chicken egg, but think about putting a chicken egg in your freezer. You know, it's probably, we don't do it. I don't know, maybe someone else does it, I don't. But you know, maybe the shell is gonna crack or the yolk's gonna be really funny or gritty when you finally thaw it. But human eggs suffer that problem from ice crystal formation. Second problem is that eggs only get to think they're fertilized once. So when an egg gets fertilized, it actually puts up a shield. A wave of calcium goes across the egg, and I think about it like in a Star Wars sense, but once an egg thinks it's fertilized, it's gonna block any other sperm from trying to get in. And so some of the early cryoprotectants or chemicals that we use to try to freeze eggs artificially tricked the eggs into thinking they were fertilized when they weren't. So not only could we not freeze eggs really well, if we were able to freeze them and they survived that ice crystal problem, once we thawed them, they weren't any good. And this went on for decades. And so egg freezing was once considered an unattainable goal from the 80s up until the early 2000s. I wasn't going to include this, but I think this audience may be interested. So I'll share why something changed. So in the early 2000s, there was a law passed in Italy. And the law in Italy stated that IVF was still legal to do, but you could only fertilize 3 eggs. And the penalty for fertilizing more than 3 eggs for physicians was jail. And suddenly people in Italy were extremely motivated to find better ways to freeze any extra eggs that they had, because when you go through the process, make 15 eggs and you can only use 3, it feels really bad to not be able to retain the other ones. And so there was this interesting socio-political thing that happened in Europe that really was one of the drivers to try to push the technology to be able to learn how to freeze eggs really well that worked. And over the next 5 to 7 years, the technology to freeze eggs changed completely, and now we're at the point where we are today where this is possible. So this was a case I was involved in. It's published. So this was a Catholic couple that and this is all public record. So physician, husband and wife, very concerned about creating extra embryos and wanted to do limited insemination. So in 2009, this was the first case of babies born from frozen eggs in the state of Minnesota. And that number has exploded since then. But we still considered it experimental. The technology evolved enough that the FDA said that egg freezing was no longer experimental about 6 years ago now. I was driving my car to work. This story came on NPR, and I almost crashed into a tree. I think I was probably the only person that came to work, and I was so pumped up that day to say egg freezing is no longer considered experimental. And this has been a game changer for what we do. I think it's opened up IVF to a lot of new patients that previously might not have considered doing it before. But it also has really been a boon for patients who are, particularly young women who are diagnosed with cancer or another serious medical illness, where even though cancer treatment can be life-saving, it's going to impair their future fertility. And because we're born with all the eggs that we ever get, when they're gone, they're gone. So a large part of my practice is also seeing women who have been newly diagnosed with cancer or another serious illness that want to be able to freeze their eggs for future use. And that's been a very rewarding thing that I've been able to see in my time. So I want to give you a couple examples as we kind of wind down about some of the patients that I've taken care of and answer the question, who does IVF? So the names are mostly changed. In one case it won't be, and then you'll see why. But who does IVF? So let me tell you about some of the cases I've been involved in. So Kyle was diagnosed with cancer when he was 15 years old, testicular cancer, and he was able to freeze sperm ahead of time, back to sperm banking, well established. But the counts were really poor. And with cancer patients who are diagnosed at less than 18 years old, this 5-year survival rate is over 80%. Cancer treatment is amazing, but quality of life issues also become apparent. So I met Kyle for the first time when he was 35 years old, married, now has no sperm after his cancer treatment 20 years ago, and we've got a couple of vials stored of his prior sperm. But I have to break the news to Kyle and his wife that the counts in those vials from our records are so low that it's not even going to be a sufficient amount to be able to try to do intrauterine insemination, aka turkey baster, according to my husband, even though we've been married 20 years and he should know better, for his wife. And so they wanted to have multiple children too. And so in this scenario, Kyle and his wife, who had excellent ovarian reserve, she was young, very healthy, she was able to go through the process of doing IVF, and we were able to create 4 or 5 embryos for them. They used 2 to have, and they had a set of twins. They were successful right away, and they have more embryos available for future pregnancies, which they are using. So In that case, you can take a relatively small amount of sperm and be able to stretch it into multiple attempts to build a family. So that's one example. Also, women with some medical conditions for whom pregnancy may not be possible or may not be safe. So we talked about Louise Brown, the first baby that was born from IVF. Her mom had both of her fallopian tubes removed. Very difficult to be pregnant without any fallopian tubes. This is very rare, but I do see some patients with a condition that has a long name, I apologize, Mayer-Rokitansky-Kuster-Hauser syndrome, born without a uterus. So this is not very common, but in the last year I've had 3 patients with this condition. So from an embryology standpoint, the ovaries form very differently than the uterus and the fallopian tubes do. So there is a condition where some women can be born with completely normal ovaries, but no uterus. There you need to get someone else to carry a pregnancy that you can create using your own eggs. There are also some women that have medical conditions that preclude safe pregnancy. So let me tell you about Ashley. So Ashley was born prematurely, and she has multiple medical conditions, including one that's called primary pulmonary hypertension. So this is a problem where if she becomes pregnant, her risk of dying in pregnancy is 30 to 50%. So it is not safe for her to become pregnant, but she wanted to become pregnant. So we had many counseling sessions with our high-risk obstetrical colleagues, and we said this is not going to be safe. So Ashley and her husband Jay needed to find someone to be able to carry the pregnancy. However, being able to find someone to carry a pregnancy comes with a lot of legal implications, and it also is a really expensive process. And the time I met this couple, they were in their very early 20s and not in a financial position to be able to do this. However, Ashley came to me with a proposition: what if my mom carries the pregnancy for me? So Ashley's mom was 49 years old at the time. Sorry, I'll get choked up. And her mom was in great medical shape. And she had to get cleared by our high-risk OB doctors to see if it was safe for her mom to become pregnant. And we all decided after a big conference talking about, is this right to do? Should we try it? Can we do it? We decided that we were going to give it a shot. And her mom became pregnant. And the part that is difficult for me to say without too much emotion is Ashley's mom and dad lived in a tiny town in Iowa. And her mom said, Dr. Jensen, what are people going to think? You know, what are people going to think about what I'm doing? And she said, I've thought about this for months, but I decided I love Ashley so much, I don't care. And I thought that is such a testament to what a parent would do for a child to try to make this successful. So this actually got quite a bit of attention. So I think this was from CBS News. But and Suzanne, her mom, actually went on to carry another pregnancy for her too when she was 51. So yeah, that's Ashley and Jay. All right, LGBTQ couples. So I'm very proud to serve this community. I have a lot of patients, LGBTQ couples. So Steve and Ryan, legally married couple, definitely want to have a baby. And 2 problems there: no uterus, no eggs. So we did, it's a little off topic here, but so when you need a uterus and eggs, we don't get them from the same person. So that's considered what's called traditional surrogacy, and most clinics in the United States do not do that. We do not do that. So we have people who will donate eggs. So we get an egg donor. In this case, it was one of their sisters, fertilized with the other partner's sperm, and then a friend carried the pregnancy for them. And that was, I have several cases that are really similar to that. That's a really wonderful population I like to work with. Okay. Finally, who else might do IVF? People who want to be parents. Think about that. So if fertility problems affect roughly 1 in 6 people, you know 6 people. So you don't have to be born without a uterus. You don't have to have cancer. You don't have to be in the LGBTQ community. People who want to be a parent. And going back to what I said in the beginning is, you know, this is often something that we just don't talk about. You know, it seems like everybody knows somebody in their family that has sex once and gets pregnant because they post that on Facebook. But that's really the exception rather than the rule. Even when humans have their best fertility, the chance of getting pregnant any given month is 20 or 25%. For couples who are diagnosed with infertility, the chance of getting pregnant any given month is 3% at best. So I'm trying to get people from 3% to 20%, or in some cases even higher with IVF if I can. And so this is around you, and I think even though we may think IVF doesn't affect us, it does. You know, it does. Somebody you know is going through something like this, and it's great to be able to serve that community. The stakes are always really high in what we do. You know, patients bring a lot of emotion, and I said earlier, you know, even when I'm doing my job the best I can, I'm only successful 60% of the time. You know, cumulatively, we can do a little bit better, but you have to be willing to ride the highs and lows with patients too, because a lot is always on the line, because you're going to change someone's life if this can be successful for them. And that's one of the reasons why I really love this area of medicine too. So kind of bringing it home, you know, I hope we've talked a little bit about the medicine, the technology, the ethical considerations we have. And I'm going to close with this quote. So actually, let me step back one more time too. So I've been married to the same person for 21 years. My husband is not in medicine. He's a mechanical engineer. We have a long running joke that I have never met a movie about a young girl in the city looking for love I didn't like, and he never met a movie about robots from the future that he didn't like. And those twains don't meet very often. So it kills me to tell you the source of this quote, but I love it because I think this summarizes really well what I think about what I do. Let us redefine progress to mean that just because we can do a thing, it does not necessarily mean we must do that thing. And why it kills me is it's from this, I think, 1991 movie, Star Trek VI, The Undiscovered Truth. But I like the thought a lot. I think that's really appropriate. And I love thinking about these big ideas and being able to share them with people like you. And with that, I'm going to say thank you for your attention tonight. And I'd welcome any questions that you have.
So we have time for about 5 to 6 questions. And I would just ask Dr. Jensen if you could repeat the question in your
Sure.
so that we can hear it.
Yes?
What is the cost? I'm sure it varies, but what is the cost of doing insurance?
Yes, so the question is, how much does IVF cost? I wish I could tell you very little, but that's not the case. So now, I will answer the question backwards and talk about insurance coverage. Insurance coverage has been something that I've seen has changed a lot in the time that I've been in the field for the better. So currently there are about 10 states in the US that have what's called mandated coverage. So if you live in one of these states, your insurance plan has to cover fertility treatment, including IVF. Illinois is an example of one of those states. Massachusetts is another example. A lot of tech companies now also offer this as a benefit. Apple, Google, Intel, even egg freezing that you can do. But when you have to pay for IVF out of pocket, the procedures are about $10,000. The medication cost is also about another $5,000. And by the time everything is said and done with all the monitoring, it's really somewhere typically for most patients between $15,000 and $20,000. Now, if you're successful and you have extra embryos, the hard part's actually making the embryos. So if you have extra embryos, we can come back and put them in the uterus and not have to start over. And the cost of doing that is about a quarter of the cost of doing IVF. But I wish I could tell you that it was less resource intensive than it is, which is a nice way of saying it's super expensive.
Slightly off topic. What is your perspective on the mitochondrial transfer going on in a few of the other countries?
Yeah, so the question was about mitochondrial transfer. This is really interesting technology. So some people have called this 3-parent reproduction. So it's essentially taking eggs from women who are older that don't have good reproductive potential and taking some of the cells from the mitochondrial cells from younger women who are egg donors and putting them in the older woman's eggs to try to support a pregnancy. Extremely controversial technology. So I don't know that we're going to get to the place where we're doing that for probably at least 10 to 15 years. It may be right for some patients. I don't think it's going to be probably the thing that we end up doing to rejuvenate the eggs of older women, just because I think it's going to be probably a little bit too controversial before we can actually do it. England is really leading the way on doing this 3-parent reproduction, but it's very regulated / frowned upon to be doing in the United States right now. But this is a great, one of the reasons why I love this, because it's a really exciting topic to talk about and think about the ethics of this 3-parent reproduction. Yeah. You had a question?
Yeah, so I'm an accounting major, entrepreneur, so often I'm thinking about the legalities of this side of things and the cost structures. So I know you talked about the insurance coverage and how over the years laws have been passed for it to be changed. But currently, do you see, are there foundations in place that are trying to get this, more laws passed for those technologies to be used, or even bases for, funding to be given to potential couples to either be granted the procedures or treatments like that? Is that something that is growing, or you would see grow potentially?
So question was about kind of financing for it, and what are, is there more legislative push / granting that can be done? Yes to all of those things. So there's a great national infertility organization called Resolve with a large presence in the Twin Cities, and they have a lobbying day every year. I'm on their National Physician Council to try to get lawmakers to better cover what we do. So there are many people who are extremely interested in this. There are some foundations that have grants for patients. I had a patient last year with a private foundation that said, send me the name of somebody that needs to do IVF and can't afford it. I would love to fund them. And that was an incredibly generous scenario. And the other part of your question that I was going to answer, I know. So for cancer patients, there are actually several programs where treatment can be reduced cost and or free, including the medicines for cancer patients. Some of that funded through pharma as well. Usually we can get all the medicines we need for free for people that are cancer patients that want to it used to be big with Livestrong, so I don't know, you guys are probably too young to know the Livestrong Foundation. Very, unfortunately, not as prominent now as it was at one point. Yeah.
You mentioned couples that might have several successful fertilized eggs. If they choose not to use them, what's the process? Is there a lot of ethical concerns? Do people just adopt them like they would adopt a baby that's already born? They use a lawyer? How do they tell someone if they have those available?
Yeah, so the question was about what, again, to access embryos and what you do with it. I do think this is one of the things that we need to counsel patients better about upfront before they choose to do it. Number one, I think it's better to not be in this situation, but there are a lot of embryos in storage right now. So what can be done? So if couples want to donate embryos to another couple, it is very involved. So there are a lot of legal steps that need to be done to sign away your rights. And this is definitely not apparent, but when you are donating your embryo to another couple, in the eyes of the FDA, so that's the government, it's like you are giving someone your kidney, you're giving them your tissue. And so anyone who's ever been involved, probably no one here, but in medicine where you're doing, anyone donating blood. When you donate blood, you get asked a million questions about the last time you were in jail and things like that, and you get screened for a bunch of things. Same process has to happen, but with even a higher level of scrutiny if you ever become a tissue donor. So the people that are going to donate their embryos, they actually do have to do a lot of complicated FDA-mandated tissue and donor screening to make sure you're not HIV positive, for example. And that process happens. There's also a separate legal process, but it's also very clear that when you go through a licensed clinic, once the gametes, in this case embryos, are out of your hands, you have neither rights nor responsibilities. So there are some people that want to have a more open relationship. I have a patient that has had 3 children through 2 different families that have donated embryos to her, and they actually do have an open relationship, but legally they would not need to do that for rights and responsibilities. I thought of one more thing to tell you. So I wish we had hours to talk about this because this is another fascinating area, but one area, because what we do is so expensive, there have been a lot of underground sperm donors. So when I started in this field, sperm was about $200 a vial, and now it's about quadruple the cost for one attempt if you buy sperm from a sperm bank for pregnancy. And so there's been a whole wave of underground donors who are willing to donate for free. So that has become sort of a big Craigslist kind of segment, where I think another interesting part of what we really don't do, because that's not part of what we are, but there have been a couple of interesting legal cases over the last decade about people who have, outside of regular clinical channels, donated sperm essentially to strangers, and now have legal obligations to any offspring that are there. So go through a clinic, that's what I would tell you. Good.
Yeah. I was actually born through IVF.
Oh, thank you for sharing that.
Yeah, I'm a triplet.
Oh, wonderful.
And I was born very prematurely. And I'm wondering about, you mentioned there are health issues for premature babies to eventually have kids. Does it, is there a correlation between, you know, how early premature they're born with the effect of difficulty?
Sure. Okay. So let me, first of all, how wonderful that you were born from IVF. How old are you, if I may ask?
22.
22. Okay. So one of the things that's also changed a lot since you were born is now we actually put fewer embryos in the uterus. So the amount of triplets that we see now is lower than it was in the past. When IVF was less successful, we did put more embryos in the uterus. That was a routine practice. And so it's not actually the health of the offspring. So it's not your health. What I meant when I said it's a more medically complicated pregnancy is when you're pregnant with twins or triplets, you need more monitoring, you need more appointments, you have a higher risk of needing to have a C-section. Moms who are pregnant have a higher risk of developing things like diabetes in pregnancy, but offspring are fine. So we don't think that that is something that affects your future fertility potential. And as far as, you know, is it different to be born from, you know, a health standpoint at 24 weeks versus 34 weeks? Yes, you know, there's a lot of fetal development that goes in between. On average, triplets are born in around 31 weeks on average. I don't know when you're born, but, you know, you typically see from the long-term health standpoint that the long-term health outcomes are really good. But from a future fertility standpoint, we don't have a reason to believe that you should have that same issue going forward. I hope that's reassuring.
Yeah.
And being generic all the time. Yeah, I'm sorry, you had a question too.
Are the embryos tested like for the genome? Like, do you get to do that? And do parents get to choose what embryos are inserted after that?
Thank you for asking that question. So also, I wish we had 3 more hours to talk about this because that's a place where the needle has moved as well for us. There is a way that you can test embryos. And we talked about the embryo that takes on that one that looks like a raspberry that takes on that shape. You can take a small sample, just like taking a snip of your hair, of the outside part of the future embryo, and you can send it off for genetic testing. So the purpose of this testing, it was invented for couples who have a serious medical condition that may result in death of an offspring. So I'll give you an example. There's a medical condition called Tay-Sachs disease. And if you and your partner are both carriers and you have a child that's affected, the child will die. I mean, it's not a survivable disease. And so we are able to do things like test embryos to see if there are ones that are affected with that, with the goal of trying to have a healthy pregnancy. You also can get the genetic information that says this is an embryo that has the normal amount of information, the normal amount of genetic material to be a healthy female, the normal amount of genetic material to be a healthy male. So we do also find out that particular information. And there are times where patients can tell us if they have a preference for what they want to do. Now let me also be clear, because I think that's just something very controversial that I said to this audience. We do not encourage people to use the technology in that way at all. That is one of the things that gets detected from that. So your normal chromosomes were women, we should be 46XX. So if you had a pregnancy that had an extra copy of chromosome 21, which we call Down syndrome, that is information that we would obtain from that type of testing. It doesn't test for every type of condition though, so it doesn't pick up some things that would be like cleft lip, cleft palate. People ask about autism, we don't know genetically what causes that. So there are many things that we can't test for. It just tells us if there's a fundamental extra amount of genetic information or missing pieces of genetic information. And we can tell if it's from the sperm or the egg as well.
We have time for one final question. And
Please ask something super controversial.
What do you think about the 14-day rule in regards to embryonic research? Do you think extending it would be a beneficial thing for IVF, or do you think that it's too controversial at the time?
So, yeah, so I'm sorry, repeat the question. So your question was, what do I think about doing?
The 14-day rule in terms of embryonic research. So like, there's a 2-week period in which people can examine the embryo and study it in a lab, but then they have to discard it after the 14th day. So what do you think about preserving it past the 14th day?
So the question is kind of about like keeping embryos in our lab for an extended period of time. Actually, embryos don't grow well after the 7th day. So we really don't keep human embryos in the lab. It's very rare to even have them until 7 days in the lab. Usually they're either transferred or frozen. So I'm not aware of any place that actually extends and does that type of research. So that would be back to even more controversial than the 3-parent thing. But right now, I'm not aware of anybody in the United States that really is doing something like that, because that's not what we do in practice at all. We really don't keep embryos in the lab that long. That was
Dr.
helpful.
Jensen will stick around for a couple more minutes for anyone who wants to come up and greet her. But thank you again for coming, and let's thank Dr. Jensen.